Please note that we are recording these sessions for later distribution. Know that your names do not appear on the recording of the session or does anything listed in the chat. If you're interested in learning more about Shout and Texas Mood, stay tuned for our announcements a little later in the program. My name is Esther Gomez-Wilson and I will be facilitating today's session. Just a few quick announcements before we begin. If you haven't already done so, please enter your name, affiliation, and email into the chat function to help us with our record keeping today. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. We appreciate your support in helping us fully capture a record of today's attendance. We invite everyone to speak, but ask that you stay muted unless you are speaking. To mute and unmute, select the microphone icon on the bottom left of your screen. If you joined us by phone, use *6. You can also communicate with the chat feature there. Please remember that no personal health information is allowed when discussing case scenarios. As I mentioned, we are recording these sessions and we will make them available on our Texas Mood YouTube page. We encourage all of you to join the conversation today and to join by video if you are able. We welcome your questions, your experiences, and your perspective in today's discussion. Our didactic today is on telementoring to transform health. As always, we will start with brief introductions, followed by didactics, announcements, and end with the case presentation. In the spirit of all teach, all learn, we encourage all of you to share your experiences, questions, and insight in the conversation today. With that, we'll begin with our introductions. I'll begin with our ECHO team. Again, my name is Esther Gomez-Wilson. I am the Community Outreach Coordinator for Texas Mood and Facilitator for today's ECHO. Next, I will start with Richard. You'll introduce yourself.
Good afternoon, everybody. My name is Rich Botner. I am a assistant professor in the Department of Internal Medicine at Dell Medical School and a physician assistant in our division of hospital medicine. Excited to be here today.
Thanks, Rich. Alana. I think we're having difficulty hearing Alana. We're going to come right back to you, Alana. Andrea.
Hi, everyone. Andrea Rochat. I'm Program Manager for UT Health San Antonio ECHO. Glad to be here today.
Cato.
Hi, I'm Kato Kosaki. I am your UT ECHO IT for today. If you have any tech issues, please chat me. Thank you.
Okay. And I'm just going to go around here so we can introduce folks with us today. I see Blair on my screen next.
Hi, I'm Blair Walker. I am an assistant professor at Dell Medical School in Psychiatry and Behavioral Sciences and Chief of Psychiatry at our main teaching hospital, Dell Seed Medical Center.
Super. Thank you. Kristen.
My name is Kristen Clancy. I am a pharmacist by training, and I am the work group chair for the Behavioral Health Integration Work Group at Houston Recovery Initiative. I'm very excited to be here.
Super. Thank you. Lori.
Hi, my name is Lori Hooks, and I am the Director of Quality, newly hired at the Texas Association of Community Health Centers. I was previously with TAC for 15 years and have quite a bit of experience within the health center movement. We are trying to figure out how to apply the ECHO model to the best benefit. Our clinical team's been working on it for a couple of years now, and I'm just trying to catch up.
Super. Thank you. Veronica.
Hello, I'm Veronica Perez. I'm an addiction psychiatrist at Baylor Scott and White in Temple, Texas, and we are joining the SHOUT initiative starting this year.
Super, thank you. Maria?
Hi, my name is Maria Chaco. I'm a research associate at UT Health San Antonio. Thank you.
Thank you. Chris?
Hey everyone, Chris Moriades. I'm a hospitalist, assistant dean and associate chair for quality and safety at Dell Med, and part of the Shout Texas team.
And next I have, and I apologize if I mispronounce your name. Is it Janani?
Yes, I go by Jan. Hi, I'm Jan. I'm a hospitalist at Dell Medical Center.
Let's see, we're gonna try Alana again.
Hi there, everyone. Sorry, I was having audio issues. I'm Alana Bolton. I'm a program manager at Dell Medical School. Thank you so much for joining us today.
Okay. And I see we have B.
Hello, everyone. My name is Bea Briseida Courtois, and I'm a program manager with UT Health San Antonio. And welcome, everyone.
Thanks, Bea. Sean.
Hi, I'm Sean Wright. I'm a program director for the Recovery Support Services program at Abilene Recovery Council and work as a recovery support peer specialist as well.
Super, thank you. And I see somebody via iPhone in WBE.
Yeah, that was the main thing.
Okay, we're going to go forward. Kenneth.
Hey everyone, my name is Ken Georgie. I'm a registered nurse at Del Seton Medical Center and psychiatric mental health nurse practitioner student over at Texas Tech. And I'm the nursing representative for the buprenorphine team over at Del Seton.
Super, thank you. Courtney.
Hi everyone, I'm Courtney Denton. I am a program manager at UT Health San Antonio and excited to join you today.
Super. Let's see, we moved around a little bit here. Let's see, lawyer, L-O-Y-E-R, so I see on my screen.
Yes, it's Linda Oyer, and I'm the CEO of East Texas Council on Alcoholism and Drug Abuse in Longview, Texas.
Thank you. Sheena.
Edwards, and I'm a program coordinator at Texas Mood at UT Health San Antonio.
Thank you, Sheena. Emily.
Hi, my name is Emily Ibarra. I'm the nursing program manager for maternal substance use and outreach at Bentab Hospital, Harris Health System in Houston, Texas.
Super, thanks, Emily. Bedla.
Hi, good morning.
Bedla, I think your volume might be a little low. Hopefully that won't be an issue if you have questions for discussion later. Let's see, San Juana.
Hello, my name is Juana Fleming, and I am the ECHO coordinator for the Texas Mood here at San Antonio.
Thanks, San Juana. Sharon.
It looks like Sharon shared her info in the chat there.
Okay, thank you. Judith. Okay, we're going to move forward. Is there anybody else that I missed? My screen has moved around a little bit here. If we did not give you an opportunity to introduce yourself, we ask that you please unmute yourself and introduce yourself and where you're from.
Hello, everyone. I'm Robert Ward. I'm from Houston, Texas, peer recovery coach working for the Harris Center, working inside a grant with the Harris Health for IFPOR, Integrated Family Planning Opioid Response.
Super, thank you, Robert. Okay, well, thank you so much, and thank you everybody for being here. And with that, we're going to get started with our didactic presentation, and I'm going to hand it over to Andrea, who will be giving us that presentation today.
Can you all hear me? All right, terrific. Well, thank you. Good afternoon, everyone, and welcome to the SHOUTX ECHO. I apologize if my eyes are looking around a little bit. I'm working off of a couple different screens here. My name is Andrea Rochat. I mentioned this before. I'm the manager for the UT Health San Antonio ECHO program that's situated in the Center for Research to Advance Community Health, the REACH Center here at UT. I support a few other programs for telementoring, communications, and implementation science at REACH, but my goal today is to tell you a little bit more about the ECHO model of telementorship. I'm going to stay pretty disease agnostic during this presentation, but we're just going to do a little video first to orient you to the model. The voice here is the director of the ECHO Service Center here, Dr. Rory Allison. I'm going to mute myself so you don't hear it. Take it away.
The Project ECHO model delivers specialist medical knowledge to regions most in need. It spreads new knowledge from teaching hospitals and academic centers to the front lines of primary care and community care. Rather than expertise residing in a hospital, healthcare providers learn from experts, they learn from each other, and hospital-based experts learn from community partners as new best practices emerge. Under ECHO, community teams use video conference technology to participate in case-based learning with expert mentors. They acquire new skills that allow them to care for patients they would otherwise need to refer on. Patients with complex conditions get high-quality care closer to home from healthcare providers they know and trust. No waiting months to access care. No long trips back and forth to hospitals or clinics. ECHO exponentially increases access to best practice care by moving knowledge instead of moving patients. ECHO has the potential to increase healthcare access locally and globally. Time lost from work and school is reduced, and more patient-centered care is delivered. UT Health San Antonio ECHO, improving access to healthcare in communities. Are you part of the ECHO?
All right. There's more to it than that, though, so please stick around. So ECHO was established in 2003, so nearly 20 years ago, by Dr. Sanjeev Arora, a liver specialist in New Mexico, who wanted to fix what he saw to be a very broken system that prevented patients in rural, underserved, and remote areas from accessing life-saving treatment for hepatitis C. This was back in the interferon days, but the story remains the same these days. Wait times to get in to see him in his clinic in Albuquerque were 6 months to sometimes over a year, requiring extensive travel, coverage concerns, and all those other barriers to access that we are familiar with in this space. Dr. Arora recognized that with guidance and mentorship, local providers could deliver evidence-based care to patients right within their medical home. And that led to the creation of the ECHO model for telementorship. This is the part you'd write down. It's a hub and spoke model of guided practice and telementorship that connects community-based health workers at spoke sites with a multidisciplinary team of subject matter experts at a hub to share didactics and discuss real-life patient cases and scenarios encountered out there in the care community. The model is very flexible and has been adapted to topics all throughout healthcare and the peripheral fields like education, prison reform, environmental sustainability planning, and so much more. It rests on 4 principles, which I've listed here: leveraging technology and scarce resources to grow knowledge network, improving outcomes by sharing best practices. The heart of the model is really case-based learning to foster deep knowledge and a sense of self-efficacy, and data tracking to measure impact and drive quality improvement. The model is highly adaptable, but it typically includes brief evidence-based didactics. And when I mean brief, for a hour-long session, you're talking 15, 20 minutes on a relevant topic for that ECHO. And then really the heart of the model, as I mentioned before, presentation of de-identified cases and scenarios from participants, followed by interdisciplinary collaborative discussion to unpack the case or the scenario and work towards recommendations on next steps. It's very typical in ECHOs to get CE, some form of continuing education. For example, in this one, CME and CNE are both available for you to earn. So that's sort of the logistics of it, but speaking more abstractly about what an ECHO space is, it's an all teach, all learn environment. It's known for being highly interactive, for acknowledging the value of multi-perspective discussions to solve complex issues, fostering peer-to-peer and collaborative learning. It's a really unique learning environment that sort of self-selects engaged learners and keeps people coming back to, keeps people coming back to the sessions for the sense of community they find in these spaces. There are an array of value propositions depending on the stakeholder for this model. So for patients, they're getting high quality care from the group of people they know and trust. This lends itself to better engagement in care, improves health outcomes, and can help avoid those costly downstream complications. For providers and health workers, they're able to participate in ongoing dynamic learning sessions with their peers. They get the opportunity to learn from others, and just as importantly, to teach others. Free CE is often an option, opportunities for professional networking and deep learning, And then certainly important in Texas, reducing that sense of professional isolation. So for clinics and hospitals, the value over time is that they can become a community leader in a new line of care delivery, losing fewer patients to referrals out, or reaching patients in those unique moments, as we can discuss later with hospital-based medication for opioid use disorder. Clinics and hospitals may also see improved staff and provider satisfaction. And then zooming way out on the system level, all those sort of things we know about improving access, there's a higher level of care available locally, and that means reduced financial waste, reduced hospitalization due to preventable issues that can be reached on-site locally by a care team, and fewer downstream costly complications. So if you are a spoke site, if you are a participant in this community of practice and learning, joining is easy. And you know this because you're all here right now. So we do encourage everyone, as Esther said, to join by video for the discussion portion of the session. It really helps to build a sense of community. We love to see smiling faces, but know that we're happy you're here no matter how you're able to join, even if it's just to call in, which you can do. All the software you need to join is free. And again, you can just phone in if that's all that's available to you. So as a model of telementoring and training, ECHO has a range of applications for improving health, which I've listed here. One of these, and I think sort of the standard expectation of ECHO, is transferring clinical knowledge and task shifting. A good example of this would be our HIV ECHO, which is part of an ongoing and open series, but it's joined by infectious disease specialists, pharmacists, primary care providers, counselors, mental health experts, community health workers, and case managers. It's a great example of how ECHOs can be really impactful as a method for slow accumulation of knowledge. Another use for ECHO is training up a workforce to deliver a new type or a new level of care. And Texas Mood ECHO, the longstanding one they've had, is a terrific example of this, bringing together health professionals across Texas to share cases, challenges, and strategies for medication for opioid use disorder. Another use of ECHO is in rapid implementation, clinic management, and operational support. So these are quote unquote systems-based or quality improvement ECHOs in which the case is not necessarily a patient, but a scenario happening in a clinic or a system. So the example I always default to would be HPV vaccination uptake in a clinic setting. So you wouldn't be talking about a particular patient in that ECHO, but you'd be talking about redesigning workflows, protocols, and educational materials to engage providers, educate your health workforce, maybe even doing some evidence-based quality improvement cycles to build up that work in that setting. A good example from our portfolio is our COVID-19 telemedicine implementation technical assistance ECHO, the longest title, which we launched very quickly last spring in response to the sudden and considerable need in the care community for practical guidance for navigating quick changing regulations, confusing technologies, and brand new protocols for launching telemedicine. We also wanted to provide clinics with support for making quick choices that could also be sustainable ones, endure beyond the emergency period. And then finally, ECHOs can be used for professional development. And in the healthcare world, professional opportunities available to learners influence the healthcare landscape. This matters in terms of having a health workforce that's representative of the communities it seeks to serve, or a leadership team that understands the lived experiences of underrepresented professionals. So this ECHO, which the text is very small, that's resources, advice, insight, support, and empowerment for early career women faculty, is put together. It's led by a national network of career development experts and academic leaders as conversations mediated by early career women faculty. And our cases in this are made up of anonymized entries discussing experiences early career women faculty have faced that exemplify any of the myriad challenges they face, such as microaggression, salary, tenure, family leave, et cetera. Just to give you a sense of the full array of opportunities, this just shows all the ECHOs we're currently running, and you'll see a couple here out of the Texas Mood program, including the one you're at and their other one, medication for opioid use disorder. And then some more that are on the horizon, recovery support services and disaster relief preparedness, also done in partnership with Texas Mood. So we're really excited for what they have on the horizon. Oh, clicking on the wrong thing. All right, you're here to learn more about supporting patients with opioid use disorder in a hospital setting. So there is some good work happening in this space, but it is a newish space, especially for Texas. Richard, who you'll hear from in just a bit, was actually part of the Colorado team you see here and has designed this new series with the objective to build a community of practice that improves Texas's capacity for addressing opioid use disorder during hospitalization through what you'll see in these series: interdisciplinary, case-based learning, and telementorship. I hope you were able to catch the webinar series that the SHOUT team recently hosted, but do know that those resources, those recordings are available if you're looking for them. It was a great series to overview the importance of this work and provide some guidance on how to get started. So what you can expect from these sessions: prior to the session, you'll receive correspondence from the SHOUT Texas team. You'll receive solicitations for cases if you're interested, and usual resources. And then you'll show up to the session itself, which will include what you've seen so far: introductions, brief didactics, and then de-identified case presentations from the care community. This team has put together two approaches to how cases can be received. One is that standard clinical case I described before, and then the other one is a systems case form. And the team is here to talk you through whichever one is maybe more appropriate. The sessions, after that brief case presentation, the sessions will then move on to an interactive interprofessional discussion about the case or the scenario, with the idea to sort of work the conversation towards recommendations on next steps. And then closing remarks, and we're out. After the session, you'll receive communication for your continuing education, as well as resources and recordings, all from the MOOD team. So just some last thoughts from me. ECHOs are really dynamic and unique learning spaces, and so I encourage you to keep showing up to this one and help us to shape it. It's all teach, all learn. Every voice matters here. And we do encourage you all, whether you're joining as a subject matter expert or as somebody very, very new to this topic area, show up with that learner's perspective and share the challenges you're facing and the solutions you've found along the way. And feedback is essential for the team. They're ready and willing to receive it and to use your help to guide these sessions. In just a little bit, Esther is going to present more on the Texas MOOD programming, but I do want to share just the UT Health San Antonio ECHO contact information if you're interested in learning more. Again, I'm excited to see this launch. This is a great group of people putting together a highly needed ECHO. So thank you all for joining.
Thanks so much, Andrea. Now we'll open it up for any questions for Andrea regarding our new, and like she mentioned, we're very excited to be bringing you this new ECHO series. So if you have any questions about our format or going forward, please, we will open up for any questions or comments for Andrea.
Andrea, it's Blair. Just curiosity, for those of us who are willing to like share our info like in the chat, for instance, in case anyone needs to like contact us offline, is there anyone like collating everybody's info? That's, you know, it might be kind of fun to have sort of a contact sheet of people. Anyway, just thought I'd ask.
Yeah, actually, you see that the little red icon at the top means the session's being recorded. That does mean that the chat's being recorded too. And I think that's a great suggestion for the team to capture what's in the chat, create a contact list, and share it out. And I mentioned this, we're so used to people just speaking, but also the chat is another great space to share comments, share questions, share challenges.
Any other questions for Andrea? We'll move along, but certainly if you have any questions as we go along in the program, and she certainly will be available following our case presentation as well. So with that, we're going to move on now to some brief announcements. If I can ask ECHO IT to post our announcement slides. Again, we want to thank you for joining us today and support the, in our new program, the Support Hospital Opioid Use Disorder Treatment ECHO, also referred to as our SHOUTX ECHO. Texas MOOD is the largest training and technical assistance center focused on SUD in Texas, and we act as a one-stop shop for those working in addiction treatment and recovery services. Texas MOOD offers Next slide, please. Texas Mood offers education, training, resources, and research for the SUD healthcare workforce. Our clinical services are focused on expanding access to compassionate evidence-based treatment and recovery support services for the uninsured. Our telementoring efforts aim to improve the quality of care and expand our skilled treatment workforce across the state. For many, these trainings mean the difference between life and death, active addiction, and recovery. We also offer quality get waiver trainings, and we can customize these trainings to groups who may be interested. We've trained over 800 providers across the state of Texas in the DEAX waiver. Next slide, please. Support Hospital Opioid Use Disorder Treatment, SHOUT, is a program at Dell Medical School at the University of Texas at Austin and UT Health San Antonio's Texas Mood that is working to increase access to substance and opioid use disorder treatment and harm reduction during acute hospitalization. SHOUT's mission is to expand their proven model of hospital-based treatment for OUD to all hospitals in the state of Texas. To do that, SHOUT has developed a robust collection of education and coaching opportunities, a monthly ECHO series, where we are today, a monthly general office hours, bi-monthly OB-focused office hours, and an expansion pilot program, which can include $35,000 in seed funding to start similar programs at hospitals across the state. Next slide, please. We hope you can join us at our next Shout Texas ECHO, set for Thursday, July 15th, where we will hear from Richard Botner on applying systems approach to OUD in the hospital. Next slide, please. You may sign up for all of the Shout Texas educational opportunities on our website at shouttexas.org. The next round of pilot site seed funding will be opening in the fall. If you or your organization is interested in this funding opportunity, please email the Shout team to get connected at shouttexas@austin.utexas.edu. Next slide. In an ongoing effort to provide you better services and support, we would like to request your feedback about today's session. We will be emailing a survey link this afternoon, which will only take you about 2 to 3 minutes to complete. The survey is also how you will get your CEUs for today's program and must be filled in within a week of the session for those credits to be issued. We thank you for your support and we hope to see you next month. I'd now like to introduce and hand over to Richard, who will present today's case presentation for discussion. Echo IT, if you could share the case template, please.
Thanks, Esther, and hi, everybody. I'll be presenting today's case. It's probably worth quickly mentioning that I am part of the Hub team, as you see on the screen, and I'm one of our Hub experts. And so we thought to kick off our ECHO, it might be helpful if I sort of frame what a sort of case discussion might look like for the future. So I'm going to be wearing my case presenter hat for this, not necessarily my Hub expert hat. And the goal is that any one of you who's attending today or any of your colleagues is highly encouraged to submit a case for your own. So you can literally just sort of slide right into the same role that I'm about to assume for today's session. So with that, I'll kick off our case discussion. So this is the case of a 42-year-old male who was admitted to the hospital, has a history of opioid use disorder. And there are 3 sort of questions that I was hoping we could address by going through this case. One is, how do you assess patient readiness for hospital-initiated buprenorphine in the setting of having used illicit opioids in the hospital room? And we'll talk about that in just a minute. How do you build trust and rapport with hospitalized patients who have a history of drug use? And then how do hospital-based interprofessional care teams function to initiate buprenorphine therapy? So a lot of things to talk about here and to unpack. And so I'll kind of just go through this case real quick and then we'll get to those questions. And I appreciate your feedback. So this was a patient who was admitted with infective endocarditis. I mentioned he's 42 years old, came to the hospital with a 7-day history of progressive dyspnea, fevers, chills, and cough. His past medical history is that he actually has a history of infective endocarditis and was at our hospital twice previously, recently. And each time he was there for less than a week before self-discharging. And I'll explain a little bit more about that in just a minute. And for those who may not be familiar, infective endocarditis is typically a 6-week, not necessarily 6 weeks in the hospital, but it's a 6-week treatment with intravenous antibiotics. And so having left 1 week into the hospitalization, obviously did not complete that course of treatment. He's not on any medications at home. In the hospital, he's on intravenous antibiotic to address his endocarditis. He's also receiving oxycodone 5 milligrams every 6 hours as needed, but only for severe pain. And then he has a hydromorphone 0.2 every 4 hours available for breakthrough of that pain not covered by the oxycodone. His social history, he has a long-term girlfriend in Austin. They live together in a apartment. He's been incarcerated, and so he was recently released, and that's who he has been living with since that time. He doesn't have children, primarily uses public transportation, does not currently have a job. He is or does have a sort of remote history of psychiatric hospitalizations related to suicidal ideation. This was well over a decade before we had met him. And so just to give you some context about where we are in the hospitalization timeline in this case, sort of what slice of the hospital timeframe we're looking at. So he presented with signs of sepsis. He was resuscitated in the ER. Now he's in the acute care area of the hospital. He did not require intensive care unit admission. He was initially started on broad spectrum antibiotics. His blood cultures grew gram-positive bacteria. A stat echo revealed a vegetation, basically the clinical picture for endocarditis. And of course, with the history of endocarditis, that's where we were thinking clinically. So antibiotics were started. And around the same time that the antibiotics were started, that we were sort of addressing this infectious disease process, the patient was saying, "I'm really concerned about my opioid withdrawal, and can we please address that as well?" And so about 24 hours into his admission, the nurse went to go check on him, and he was found to be injecting what we assumed and what he admitted ultimately was heroin through his IV. And so that's kind of where we are in the case right now. If you could just scroll down a little bit more, please. We did not check his PDMP. And so the primary team was called to the bedside. Basically, the nurse discovered that this patient had been injecting drugs into the IV. There was sort of this ensuing conversation. Conversation got heated. Patient's now really agitated, repeatedly saying, nobody is paying attention to what's important to me at this moment, which is opioid withdrawal. All you care about is treating my heart infection. Hospital administration is now involved because it goes up the hierarchy, the food chain, that this patient is injecting drugs in the hospital. That's seen as a liability to the hospital. So now there's discussion of potentially administratively discharging this patient or having some sort of behavioral contract that if this activity happens again, he would be discharged. And so obviously this patient's really upset about these circumstances. In terms of his substance history, occasional cocaine use, drinks a few beers a day. He describes his dominant substance use disorder as being heroin, uses about 1 gram every other day on average. And then you can see on the right side there, has not really engaged with substance use treatment prior to this hospitalization. A little bit of counseling at one point, but not otherwise. So that's the case. That's sort of where we are in this timeline. If it's helpful, I don't know if we want to just put the questions back on the screen or if we want to put them in the chat. Or actually, I should be quiet now because now I'm moving into moderation mode and I'm just presenting the case so far. So let me pause there.
Thanks, Richard. Are there any questions or comments, discussion about today's case presentation?
Can you put up the questions again? I don't remember them. So my first impression is this is a hard case. We've had similar, this is Emily from Bentob and Harris Health System in Houston. We've had cases where we've had patients using, and it's in the hospital, and it's never a black and white approach. Like, I don't necessarily believe in the hard and fast administrative discharge, but all I can say is there's never really a hard and fast approach. I think the first thing you would want to do is have I think a clinician that, you know, because we have some really great addiction medicine specialists. And so having someone that has, and it doesn't actually have to be an addiction medicine specialist, but someone who has the clinical artistic ability to have a conversation with the patient to elicit where they are and readiness to change. And, you know, is this going to be an opportunity for them? Like that's the question to start treatment, or, you know, what is really their next step for them personally. So, and that doesn't, like I said, doesn't have to be an addiction medicine specialist, but who's most in the best position to have just start that conversation. That's one part, but the other part is really the administrative discussion as well, because that's valid and it needs to be addressed as well, and very clearly at the same time. No one's trying to like have no rules at a hospital because it's a safety issue for other patients, and that was kind of our thing, is like it's a safety issue. And not only with other patients, but using and us not knowing that they're using and giving them other medications is very dangerous. So having that conversation in that context as well. So those are just my initial thoughts to start talking.
That's great. Emily, it's Blair. So I'm with psychiatry at Del Seton and part of the kind of hub for this ECHO group. And yeah, I think kind of exactly what you're saying. I think having folks who, and I think what will happen is it spreads over time, but like coming to talk to that person, I think one of the big low-hanging fruit things that is a change in the way we think about helping these patients, which is trying not to use too much judgment. And while still setting the safety boundaries and the expectations for appropriate behavior in the hospital. Like we cannot allow you to continue to use IV heroin in the hospital, but at the same time, like that doesn't mean you're a bad person. That means that you have a serious substance use disorder, and how do we help you with that? And so I think part of it is like checking, you know, and it's happened in our hospitals. We've been working on this, is that it turns out that over time, all the providers have sort of changed their attitude about how they address this, but you have to sort of practice it. You know, since we have something else we can do, it's sort of entering the room with like a, hey, I heard that the nurse walked in on you injecting heroin into your IV. Like, let's talk about that. Like, what's going on? Are you craving? Like, how can we help you? Rather than get out of our hospital, how can we help you not do that again? And we cannot allow that. That's not safe. The other interesting thing you mentioned was like the administrative discharge. I'll tell you, in our hospital, as an aside, not necessarily an opioid use disorder thing, but as an aside, in our hospital, we have what's called like a behavior contract that we do use for patients who are engaging in inappropriate behavior and where it's not completely ludicrous to discharge them. We do use that. And sometimes even with these patients, we say, hey, we really want to get you on buprenorphine. But if they're struggling, sometimes we might also include that as a future potential concern. Now with these patients, not so much when it's just using in the hospital, more like being hostile to the nurses or using terrible language or throwing things at somebody, not so much using. And again, we sort of separated that idea. Using in the hospital means you have a serious substance use disorder. It doesn't necessarily mean that you have like this behavioral concern that needs to be checked in that same way, but sometimes we'll use that as well.
I really like that distinction. I actually never thought about it that way, because I would say we're not there yet at all with our team. So I work with pregnant women And so you can imagine that in the OB world, we're even more judgmental. And I'm a nurse and we're the worst. Or I don't know what, I guess the system is the worst, I would say, how we treat patients.
It's nice to know though, that that's not like, that might be more universal. I think it's natural in the OB world to have, you know, in psychiatry, we talk about countertransference. So again, like how we all feel, how our patients make us feel. And when a patient is using substances under our noses at the hospital, it feels like an insult. When a pregnant patient is using substances, it feels like they're a bad person naturally. Like, even though we're not consciously thinking that, I think subconsciously we think you must be a bad person because you're hurting your baby.
Well, and like our neonatologist will like, so maybe we even on the OB side will get all on the same page, and then the neo team is just like extremely angry and just doesn't want to have any you know, discussion, just like, you know, all bets are off kind of thing. But I really do think that's an interesting approach to say, is this a behavioral concern? Are they being, quote, abusive to the nursing staff, the physicians? Because that is a separate concern, and that's something that's very real that so many hospital staff deal with regularly. That's very challenging. Versus, obviously, it's not safe, but is it more of the, you know, the approach to treatment, and how do we therapeutically address that?
Yeah. Does anybody else have any other thoughts?
I have a question. So as we're hoping to initiate buprenorphine in the hospital setting, I hear when we're transferring care that possibly there were some points missed where maybe his use history was not properly documented or it wasn't communicated. So I'm just curious, from the point of admission from the ER, what is the procedure for notifying someone, hey, this patient uses heroin or other, you know, other medications, other drugs, and may experience withdrawal in this hospital? Because what I'm hearing is this patient was anxious and communicated a need that wasn't addressed. Why would he trust us to initiate buprenorphine in the hospital? And I'd like to hear from Emily also, and our original presenter.
Yeah, I think that's it's a good question. In this particular case, you know, I think there was, and this is a really good question to think globally as well, because there actually really are no validated screening tools for inpatient use. There are some in the ER setting, which is not your question, but it's in another sub, maybe for another echo. But for this case, this was a patient who sort of had a clinical picture and a history from previous hospitalizations that was quite indicative, both by self-report and by kind of clinical presentation, of somebody who had a history of intravenous drug use. And even in this hospitalization, like to your point, was saying like, this is why I'm here. And so I think this case is one where the handoff wasn't necessarily the issue. Like, that was the reason for admission. And so the nurse would have had this handoff with the next nurse, and the primary team would have had this as the main handoff for the next. I guess I don't know that 100% that that's what happened, but this was like basically the sole reason for admission. So I think, you know, looking back on the case, everybody knew what the diagnosis was. I don't think anybody knew how to handle it, how to approach it, or what to do.
I was going to add, Kristen, those are some really great thoughts that I had to, coming from a training, or my previous institution, we were fortunate to have an addiction consult service. So as soon as patients similar to this or with any kind of concerning histories, we would be consulted, go see them immediately, and then we could induce them on buprenorphine or methadone, whatever it was, to treat their withdrawal, also treating, you know, tobacco, withdrawal, things like that, to get them more comfortable so they're more willing to cooperate and engage in their care, and then follow them along and then adjust depending, you know, if they needed surgical procedures or other pain managements. So ideally that would be how it goes. They get treated, you know, when they come in first thing. But, you know, at my institution now, we don't have that luxury. So part of the reason I'm wanting to join this initiative too, so we can make things better. But that, you know, if you can get them engaged right from the get-go, then they can start building that rapport and trust. It's just, if you don't have that set in place or those resources, it becomes a little bit tougher.
I'm really glad that you mentioned the nicotine, because that is a substance that people get addicted to. And there's very little stigma these days, you know, associated with it compared to other medications. And we can prescribe medications immediately in the ER to kind of mitigate the withdrawal effects. So it's very interesting that we're not in that space for withdrawal from other drugs abuse.
Yeah, and especially it works so well. It works well and it works rapidly, probably better than nicotine replacement. The thing I was going to say was, you know, a number of us who are the hub content experts, we weren't content experts on this 3 or 4 years ago by any means. Like, I'm a psychiatrist, I use some buprenorphine a little bit, but not the way that we've been using it now. And I think we've dropped a little bit here and there, like the B team, the buprenorphine team, like I don't know if everyone kind of knows what we're doing in Austin, but we basically developed with a fully interdisciplinary group of folks, psychiatry, internal medicine, palliative care, pharmacy, chaplain, social work, nursing, like kind of someone from everyone in the hospital who just had sort of passion about this and like got together and developed this sort of roving consultation service to see people. And we basically sort of developed this expertise over doing this over time and have learned how to kind of interact with these folks and enter the room. You know, I'm the main psychiatrist in the hospital, so I get called a lot when people are having trouble misbehaving, so to speak, we'll say. And so I get called on this kind of thing all the time. Mr. So-and-so was doing X, Y, and Z. Like, he's talking about leaving AMA, get up here, help us. And I think often, you know, I think bringing up the fact that we missed that you were in withdrawal. First of all, withdrawals, one of the first things I ask people, you're uncomfortable, you want to leave, tell me what's going on. Is it possible that you might be withdrawing from something? How can we help you? Because even nicotine withdrawal is enough to make people want to get the heck out of the hospital. And our hospital in particular, like, we're a hard stop, you know, we're on a UT campus, we don't have any smoking. So people don't go down to the curb to smoke, or they're not really supposed to, at least. So I think bringing that into the room, and when it's like, oh my gosh, I'm so sorry we missed that, and take it more onto all of us as a team, like we missed that. I want to help you with that right now. Like, let's talk about options and what are you interested in? And again, in this like non-judgmental kind of, I take the stance of just like, this is just like any other medical problem you have. Like, these are the different insulin options you have. Let's talk about the options for your diabetes. It's the same sort of thing. It's like, oh, we've got options for that. Which ones do you want to think about? And it's not just buprenorphine. We will sometimes use methadone for people as well. You know, setting the boundaries and caveats of, it's harder for us to get you straight into a free methadone clinic, for instance, depending on your medical, you know, how you're doing. Like, we need, you might be on the more frail side that methadone might not be indicated, whatever, but we do that too. And I don't know, sort of meet the person where they are in a patient-centered way. What we've seen naturally happen too is that as the nurses have seen us, and we've developed this expertise over time too, about just how to talk to people, that other people are doing the same thing. And the way we set up this service, the way it's worked in our hospital, is we have a way for any staff, anytime they pick up on someone who might need our help, the B team help, anyone can call. It's not like it has to be the primary team doctor, the nurse taking care of that person, the ER triage nurse, the social worker, the pharmacist. Like, anybody can poke us. We have a secure texting app that we use, and they can sort of send it to our whole group and just say, hey, Mr. So-and-so is coming upstairs from the ER and he has a history of heroin use. Might need to see you guys tomorrow. Like, say it's 7 o'clock at night. Might need to see you guys tomorrow when you're back. You know, you might reach out to the primary team and see if they're cool with you seeing them. So it's a way to try to capture this and not miss these patients like we have, and like we always have. So it's kind of improved our game in reaching these patients quickly before they bounce out of the hospital.
One thing that I'll say, just when you're kind of discussing, and this picks up on what Dr. Walker was just mentioning, but I've spent many years working both in the ER and directly on the street to people who use drugs. And something that I hear over and over and over again is this idea that they're spoken down to by people in the hospital. Whereas with other patients, we're more than happy to embrace the idea of the team model. Like the patient is on the team, the patient is part of the decision process. And I feel like that's something that we don't afford to people who use drugs. So like one thing that I noticed when Rich was going through his case presentation was this idea of like, well, this is a safety issue that this patient was injecting into the IV. And that's a really fair point. But I've heard a lot of folks that get kind of administratively discharged from the hospital for things like that. And it was never really relayed to them at any point why that was. And it comes off as just like, they were sick of me and frustrated with me and didn't want to deal with it anymore. So something that I've spent a lot of time doing is sitting in the back of our truck and saying, hey, I think this is what was going on. Did you know that if you inject heroin that you buy from the street into your IV, that it can cause a really nasty infection that's hard to treat and make you even sicker? Did you know that maybe if you inject heroin and the nurses don't know about it, that you can accidentally overdose and no one knows to watch for that? And then you kind of see light bulbs coming on. They're like, oh, okay. So a lot of this is like, what would you do with another patient that might also be doing something? Like, what if a patient was bringing in outside meds and you caught that and it didn't have anything to do with addiction? Well, you'd probably sit down with them and say, here are the reasons I'm worried about this. Can we talk about not doing this anymore? Can we talk about like finding a middle ground? I find that really, really helpful. The amount of time I've spent just sitting down with people and just walking through real basic stuff that wasn't extended to them by physicians and nurses is telling. So I would definitely just, if you're frustrated with someone or you don't think they're getting it, make sure you've explained exactly why it's a problem so that they aren't interpreting it as you just don't like me, because that's easy.
I love that, Claire. I'm curious, tell us what you do. I think I didn't catch that before.
Yeah, so I'm a harm reductionist and I'm also a paramedic. I spent about 8 years in the ED at St. David, South Austin, and I do harm reduction work directly on the street with folks who inject drugs or use drugs, mostly injection. So yeah, so for example, I have someone that I was recently able to help get into MOUD, very excited about it. But one of the things that I spent a ton of time doing was she would come to me and she said, I know I'm out of my mind, but can you talk to me for a minute? And we would sit and she would point to like little hematomas under her skin where she had injected. And she said, I'm really worried that I'm going to get a stroke from this. And we would talk about the difference between DVTs and little hematomas and bruises and how, things that she can watch for if she is worried about this. And, are you moving and sitting all day? Because she was clearly worried about, clots from all of her injecting. She was worried about vein damage. She had a friend that had phlebitis. She had a friend that had osteomyelitis. So we talked about all these different warning signs. And she'd had a lot of experiences. And I know how that is in the ED. I know how incredibly exhausting and grinding that work is. But she had a lot of experiences where she would go in with this and they would just be like, oh,
yeah,
not what that is. I'm going to DC you home. Google it if you have a question next time, sort of a thing. And I know that's easy. And, I don't want to cast stones. We've been there. But I feel like a lot of it is that once we realize that the patient uses drugs, we just kind of shut off compassion brain. It's really easy to do. And then instead of it being like a patient that you need to discuss and educate, it's just something you kind of need to clear off your board. So I would encourage us to check in on that. I was really surprised when I started because hearing lots of stories about how recalcitrant these patients are, sitting down and talking to them, how they were just like any other patient that hadn't had stuff explained to them before and just really wanted to spend some time with someone from healthcare who would just look them in the eye and patiently listen and discuss what was going on. It made tremendous differences.
I really love that. I was going to mention, I had a sort of a motivational interviewing guru, teach me just the sort of like the idea of when you come up to see somebody, when you're talking to somebody about this stuff, you're really like, the problem is not the patient. the problem is in front of the patient. And it's like you're standing together, looking at the problem together side by side, instead of you patient are the problem, or you person, I should say. I know not everybody thinks about patient. But like, I think that's always really helped me frame it in a way in the room with the person that I'm here to help you figure out how to fix that issue and explain why I'm worried about that issue. And we tend to, with that behavior contract stuff, we actually have sort of a protocol of how we use that, and we take them through the explanations of why we're setting the boundary and why we're concerned. And, you know, moving forward, we really don't want you to use your IV for anything other than what we're putting in it. And this is why. And I sometimes, honestly, the IV thing, there's always this tension. I just had a patient like last week who'd been sober for 8 months, you know, decided to come off of methadone. And a couple of weeks after coming all the way off methadone, had a relapse or recurrence to use and injected twice. That's it. And developed a terrible hip infection, right? And so he's in the hospital and he needs like weeks and weeks of IV antibiotics, but he's so in the recovery mindset already. Like he's there. And there was this tension of, and it used to be hard stop, you may not go home with home IV antibiotics if you have a history of IV drug use. And there was this tension that he had already picked up on when I finally, you know, when I got to him as part of the sort of the buprenorphine team or whatever, of no one had actually said it out loud in the room. And I just asked him point blank pretty quickly, can you promise me you're not going to use your IV for anything but the antibiotics? And he was like, I wish somebody had said that to me the last day. And sort of, he again, just the most lovely person to work with, and was already in that headspace and very upbeat and pleasant, but it had been in the back of his mind too. He was feeling that tension from all the docs. Nobody was really saying anything. And I think that sometimes takes practice for all of us to, like, when something's ought to be said, again, not infantilizing your patients and just bringing it to their attention and looking at them as a partner rather than like a child that we need to treat, but like not, I don't know. I think it's something that you're right, Claire, that we do more often with substance use disorder than with folks struggling with other stuff. Yeah. Almost like they don't have control over themselves, and you can't like talk about this sort of stuff.
Yeah. They've been doing, and you probably know about this, but they've been sending folks home with indwelling IV catheters in Singapore, like for at-home antibiotics. And they have a whole way that they coach people before sending them home on that. They have checks they send, and this is something that would take a big lift to do right now in the States, and I acknowledge that. But they send nurses in to check on things. They make it crystal clear what they're gambling with if they, inject something that's not sterile into their, their bloodstream. So yeah, I mean, there are ways around that, but it's amazing to me how if you just like lay out, here's why I'm concerned, because I promise a lot of the assumption is going to be that the doctor just doesn't care and wants to get rid of me. So as soon as you can disabuse them of that assumption, it's like a veil lifts. It's really powerful.
Absolutely. The conversation is absolutely powerful. Everybody's engaging. I wish we could go on, but the interest of time, we've got to keep things moving. So what I'd like to do is I'd like to ask Rich if he has any last thoughts. And again, thank you so much, everybody, for all the great questions and experiences that you've been sharing with us today. Rich, I'm going to hand it over to you for just a quick last thoughts or summary.
Yeah, sure. As the case presenter or as the hub person?
As both today.
So this was super helpful as the case presenter. I think a lot of our discussion sort of centered around the second question I had posed around building trust. And I think we all recognize some of the challenges that exist there, but I think we also heard a lot of the opportunity and a lot of the, what has worked well for people. So I really appreciate the rich discussion. And then as one of the hub team members, please do consider presenting a case of your own. As you saw, it's pretty low-hanging fruit, simple, straightforward, friendly environment. We have two different case forms. One is more of a traditional clinical case like I presented today. There's also a systems-based form. So if your question is not how do we start buprenorphine? But if it's more, how do I get my chief medical officer on board? And this was a scenario where I presented at a meeting and got some awkward pushback that I didn't know how to navigate. Use the systems form, and we can certainly address some of those questions as part of our ECHO as well. So thank you all so much for being here today. And we look forward to you joining next month, third Thursday of every month, 12 to 1 p.m.
Super. Thanks so much, Rich. And also we want to thank Andrea, of course, for sharing the summary on what our an ECHO consists of, and certainly what we can expect as we continue the series. Again, thank you all for your participation and joining us today. And we will, good afternoon, and we'll see you next month.